This video will go over the problems caused by cirrhosis and the ways that those complications or problems are treated. The priority collaborative problems for patients with cirrhosis include fluid overload due to third spacing of abdominal and peripheral fluid, potential for hemorrhage due to portal hypertension, and potential for hepatic encephalopathy due to shunting of portal venous blood and/or increased serum ammonia levels. The first thing we're going to talk about is managing fluid volume. The patient with cirrhosis is expected to have less excess fluid volume as evidenced by decreased ascites and peripheral edema and adequate circulatory volume. If ascites continues, the patient will not have respiratory distress and will manage ascites by adhering to the collaborative plan of care. Fluid accumulations are minimal during the early stage of ascites. Therefore, interventions are aimed at preventing the accumulation of additional fluid and moving the existing fluid collection. Non-surgical treatment measures are used to treat ascites in most cases. Supportive measures to control abdominal ascites include nutrition therapy, drug therapy, paracentesis, and respiratory support. The patient's fluid and electrolyte balance is also carefully monitored. If the patient is jaundiced, he or she will likely scratch the skin because of excess bilirubin products causing irritation and pruritus. For skin irritation and pruritus associated with jaundice, teach the patient to use cool rather than warm water on the skin and to use a small amount of soap. Teach UAPs to use lotion to soothe the skin. Assess for open skin areas from scratching, which could become infected. When we talk about managing fluid volume with nutrition, the healthcare provider usually places the patient with abdominal ascites on a low sodium diet as an initial means of controlling fluid accumulation in the abdominal cavity. And that makes sense, right? Because we know where sodium goes, water follows. They're having a problem retaining fluid, so a low sodium diet does make sense. Table salt should be completely excluded. Low sodium diets may be distasteful, so suggest alternative flavoring using lemon, vinegar, parsley, oregano, and pepper. In general, patients with late cirrhosis are malnourished and have multiple dietary deficiencies. Vitamin supplements may be needed in order to make sure the patient's nutritional needs are being met. For a patient with biliary cirrhosis, bile may not be available for fat-soluble vitamin transport and absorption. Drug therapy used to manage fluid volume involves the use of diuretics. The healthcare provider usually prescribes a diuretic to reduce fluid accumulation and prevent cardiac and respiratory problems. Monitor the effect of diuretic therapy by weighing the patient daily, measuring daily I&Os, measuring abdominal girth, documenting peripheral edema, and assessing electrolyte levels. Serious fluid and electrolyte imbalances such as dehydration, hypokalemia, and hyponatremia may occur with loop diuretic therapy. Depending on the diuretic selected, the provider may prescribe oral or IV potassium supplements. Some clinicians prescribe furosemide and spironolactone as a combination diuretic therapy for the treatment of ascites. Because these drugs work differently, they're used for maintenance of sodium and potassium balance. All patients with ascites have the potential to develop spontaneous bacterial peritonitis from bacteria in the collected acidic fluid. In some patients, mild symptoms such as low-grade fever and loss of appetite occur. In others, there may be abdominal pain, fever, and change in mental status. When performing an abdominal assessment, listen for bowel sounds and assess the abdominal wall rigidity. Treatment involves IV antibiotics such as cephalosporins or fluoroquinolones. Another way to manage fluid volume is with paracentesis. So when you think about a patient with ascites and they have that large abdomen that's just full of fluid, one way to get that fluid out is just simply drain it. The healthcare provider inserts a catheter or drain into the abdomen to remove acidic fluid from the peritoneal cavity during a paracentesis. Procedure is done using ultrasound for added safety. In some situations, a short-term ascites drain catheter may be placed while the patient is awaiting surgical intervention, or tunneled ascites drains, can allow a patient or family caregiver to drain acidic fluid at home. Some things to remember when caring for the patient who is receiving a paracentesis is to be sure to explain the procedure and answer any questions, or refer to the provider if needed. Obtain vitals, including a weight. Ask the patient to void before the procedure to prevent injury to the bladder. Position the patient in bed with head of bed elevated. Monitor vital signs. Measure drainage and document collected fluid. Record all measurements and documentations. Label and send fluid for lab analysis. Document when specimens were sent. After the physician has removed the catheter, apply a dressing to the site and assess for leakage. Maintain bed rest per protocol. And be sure to weigh the patient after the paracentesis, documenting in the patient record both the weight before and after the paracentesis. If spontaneous bacterial peritonitis, or SBP, is suspected, a sample of fluid is withdrawn and sent for cell count and culture. A problem with excessive fluid volume or excessive acidic fluid is that excess volume may cause the patient to have respiratory problems. He or she may develop hepatopulmonary syndrome. Dyspnea develops as a result of increased intra-abdominal pressure, which limits thoracic expansion and diaphragmatic excursion. Auscultate lung sounds every 48 hours for crackles that could indicate pulmonary complications depending on the patient's overall condition. For the patient with hepatopulmonary syndrome, monitor his or her oxygen saturation with a pulse ox. If needed, apply oxygen therapy to ease breathing. Elevate the head of the bed at least 30 degrees or as high as the patient wants to improve breathing. This position, with his or her feet elevated to decrease dependent ankle edema, often relieves dyspnea. Weigh the patient daily or delegate and supervise the activity. Fluid and electrolyte balance problems are common as a result of the disease or treatment. The elevated BUN, decreased serum proteins, and increased hematocrit may indicate hypovolemia. If medical management fails to control ascites, the healthcare provider may choose to divert ascites into the venous system by creating a shunt. Next, we'll talk about ways for preventing and managing hemorrhage. The patient is expected to be free of bleeding episodes. All patients with cirrhosis should be screened for esophageal varices by endoscopy to detect them early before they bleed. If the patient has varices, they are placed on preventative therapy. If acute bleeding occurs, early interventions are used to manage it. Because massive esophageal bleeding can cause rapid blood loss, emergency interventions are needed. Ways that we treat and prevent and manage hemorrhage include drug therapy, endoscopic therapy, and other interventions which we will discuss. The role of early drug therapy is to prevent bleeding and infection in patients who have varices. A non-selective beta-blocking agent, such as propranolol, is usually prescribed to prevent bleeding. By decreasing heart rate and the hepatic venous pressure gradient, the chance of bleeding may be reduced. Infection is one of the most common indicators that patients will have acute variceal bleed. Therefore, patients with cirrhosis with GI bleeding should be receiving antibiotics when admitted to the hospital. If bleeding occurs, the healthcare team intervenes quickly to control it by combining vasoactive drugs with endoscopic therapies. Vasoactive drugs, such as vasopressin and octreotide acetate, reduce blood flow through vasoconstriction to decrease portal pressure. Octreotide also suppresses secretion of gastrin, serotonin, and intestinal peptides, which decrease GI blood flow to help with pressure reduction within the varices. Endoscopic therapies include ligation of bleeding veins or sclerotherapy. Both procedures have been very effective in controlling bleeding and improving patient survival rates. Esophageal varices may be managed with endoscopic variceal ligation, also known as banding. This procedure involves the application of small O bands at the base of varices to decrease the blood supply to the varices. The patient is unaware of the bands and they cause no discomfort. Endoscopic sclerotherapy, also called injection sclerotherapy, may be done to stop bleeding. The The varices are injected with a sclerosing agent via catheter. This procedure is associated with complications such as mucosal ulceration, which can result in further bleeding. If rebleeding occurs, rescue therapies are used. These procedures use a second endoscopic procedure, balloon tamponade, and esophageal stents, and shunting procedures. Short-term esophagogastric balloon tamponade with esophageal stents is a very effective way to control bleeding. However, the procedure can cause potentially life-threatening complications such as aspiration, asphyxia, and esophageal perforation. Similar to an NG tube, a tube is placed through the nose and into the stomach. An attached balloon is inflated to apply pressure to the bleeding variceal area. Before this tamponade, the patient is usually intubated and placed on a mechanical ventilator to protect the airway. This therapy is used if the patient is not able to have a second endoscopy or TIPS procedure. TIPS stands for transjugular intrahepatic portal systemic shunt. And what it is a procedure that creates a shunt to divert blood away from the diseased liver, thereby lowering portal hypertension and also bypassing the liver. Serious complications of TIPS are not common. Patients usually follow up with an ultrasound for the first year after the shunt is placed to ensure continued patency. Patients also must be monitored for hepatic encephalopathy, which can be caused by TIPS, because remember that blood is now bypassing the liver. The blood bypasses most of the liver's filtration processes, allowing toxins to circulate throughout the body. For some patients, this can cause disturbances in consciousness and behavior. Lactulose or other medications may be given to counteract this effect, and dietary modification may also be helpful. In some cases, a TIPS shunt may have to have the flow reduced or closed completely to reverse encephalopathy. Patients receiving TIPS can also have significant elevations of their pulmonary artery pressure. This is a result of the sudden increase of blood flow to the right heart. Diuretics may help to treat this problem. For this reason, patients must be carefully evaluated for right heart failure before TIPS placement.